Alrighty, so this is Jess, and we are cruising through the adrenals today. I'm going to share my screen, and we're going to finish up the rest of the slides here for the slideshow, just to let you know. We just finished with adrenals, with problems with corticosteroids and Cushing's syndrome. So let's talk about Addison's disease. So Addison's disease, Cushing's syndrome is there's too many corticoids. Addison's disease is there's not enough. So there's a low functioning adrenal gland and there's a low functioning corticosteroid level. And about 85% of the people with Addison's disease have it because they have an autoimmune problem. Manifestations include no hunger, anorexia, nausea, weakness, fatigue, weight loss. So anorexia and weight loss together in this one, anorexia and weight gain together in Cushing's, a bronze-colored skin, abdominal pain, craving salt, and orthostatic hypotension. So an addisonian crisis is triggered by stress. So people who have Addison's disease, we have to be super vigilant about when we're causing them stress, like with surgery. Also infections, or they should be on top of their immunizations. Their immunizations can hit them harder. Their vaccinations can hit them harder than the normal person. Any sort of emotional stress can also trigger an addisonian crisis. And withdrawal of their corticosteroid therapy will definitely trigger a crisis. Any sort of adrenal surgery or any sort of sudden pituitary gland destruction, whether it be from head trauma or whether it be from surgical removal. Manifestations of addisonian crisis include hypotension, so low blood pressure, high heart rate, dehydration. They have low blood sodium, hyponatremia. They have high blood potassium, hyperkalemia. They will be feverish. They'll have weakness, confusion, and shock because of their circulatory collapse. So an addisonian crisis, whether it be from surgery or infection or emotional problems, will, if not treated correctly, will cause their entire circulation. Then we have a huge C problem. ABCs, airway breathing will be okay. C's gone, just to let you know. So how do we figure this out? Labs can detect an issue. So just for your own fun information, what's happened is a patient is given a dose of IV ACTH, and then we check the blood 30 minutes and then 60 minutes after that infusion. So this is a timed lab. And if this person has no response, they have Addison's disease. We gave them this stimulating hormone, and if the adrenals aren't able to react to that stimulating hormone appropriately, we have Addison's disease. So the treatment is to manage the underlying cause. So do we have like some different surgeries that we can do in terms of like removing, like maybe their adrenals are shot because of a big tumor or something. And then we'll have lifelong hormone therapy. So these people will be on steroid therapy, and doses will be higher in the morning and lower at the night, because that's what happens. We wake up, our bodies are just like, hey, we need some energy. Let's get some corticosteroids out there. Let's get some stuff. We need to get rolling. And then at night, it's like, we don't need to roll anymore. We need to sleep. So it actually lowers down in terms of release levels. And then we will also need to be doing some Cushing's education, because if they have too many hormones, then they can be at risk for developing Cushing's syndrome as well. Hyperaldosteronism is caused by too much aldosterone, otherwise known as aldosterone. There's a couple different ways to pronounce it clearly, and that's caused by a tumor on the adrenals, an adenoma. So manifestations, they're going to be keeping their sodium. So they'll have high sodium. This high sodium also creates hypertension and a headache. And then they will also have potassium and hydrogen ion secretion. So they'll keep all of their sodium and they'll lose their potassium and they'll lose their hydrogen ions. If they're losing their hydrogen ions, then they're having alkalosis. So they'll end up with cardiac rhythm, easy for me to say, cardiac dysrhythmia, muscle weakness, fatigue, glucose intolerance, and like I said, metabolic alkalosis, because they don't have any hydrogen ions. Preferred treatment for this is removal of the adenoma. Let's just get the tumor off. We'll monitor them for fluid and electrolyte balance. And then there's medications. Medications including spironolactone. Spironolactone is sometimes used as an antihypertensive, but the brilliant part of it is it increases sodium excretion and potassium retention. So that hyperaldosteronism is reversed with spironolactone because the medication has the opposite effect of what that too much aldosterone has, or aldosterone. You can also have potassium supplements, yay, and some potassium sparing diuretics will be helpful as well for these people. So that is the conclusion of endocrine problems. I hope that you bring some questions to class, and I will see you soon.